Welcome, ladies and gentlemen, to the DIM 400 lecture on radiology of the head, with focus on pathology such as sinonasal disease and conditions of the temporomandibular joints. Dental disease will be covered in the dentistry section, and I'm Dr. LaRue, and I'll be lecturing this section. So the images from this lecture come from a page called Will's Skull Page, and his hobby is to collect skulls and identify them. And the website is skullsite.co.za. So the skull encompasses the brain and houses the sense organs for hearing, equilibrium, sight, smell, and taste, and it provides attachment for teeth, the tongue, the larynx, and muscles. And it's a very complex structure with more than 50 bones, teeth, cartilage, soft tissues, and so superimposition of features is hard to avoid, and this is what makes radiographs very tricky. The skull is symmetrical, so comparison of the two sides is helpful. Accurate positioning, centering, and collimation is very important to optimize imaging. And these days, CT has an increasing role in assessment of complex diseases due to its lack of superimposition. So the two most basic views of the skull are the DV and the lateral views. So for the dorsoventral view, the patient is placed in sternal recumbency, symmetrically, with the head extended and the hard palate parallel to the cassette. This is achieved with radiolucent positioning aids such as foam wedges and foam pillows, and the aim is to get a symmetrical view so that one can compare bilaterally symmetrical structures. For example, the mandibles, the temporomandibular joints, the tympanic bulla of the middle ear, and for example, the zygomatic arches. The lateral view, the patient is in lateral recumbency, and the head has to be in a true lateral position with the median plane parallel to the tabletop and hence to the cassette. And again, this is achieved by placing positioning aids under the nose and under the mandible. And sometimes padding needs to be placed underneath the neck and the thorax, so the head and with the head and the neck reasonably extended. It's a good overview of the skull, but there is superimposition of structures. For example, the mandibles are superimposed. All the teeth are superimposed over each other, the nasal passages, and the frontal sinuses. So if examining the nasal passages, one should center the beam over them, or if examining the cranium, it's important to center between the eyes and the ear. Again, a right lateral means the patient is lying on their right-hand side, with the beam entering from the left-hand side. So the correct terminology should be a left to right lateral, but it's easier again just to say right lateral. So the following is an image depicting some of the important skull anatomy. So please hit the pause button and take some time to read through all of them, or come back to it at a later stage and just have a read through. The anatomy of the soft tissues are also very important, as well as being able to identify the normally air-filled regions, such as the pharynx, the larynx, the trachea, the sinuses, and the nasal passages, all depicted here. So radiographs might not be great for soft tissue, but often subtle disruptions of anatomy. For example, if there's a soft tissue opacity or a mass where there should be air, this can be recognized as pathology. And please take some time just to review this slide as well and get an idea of the soft tissue anatomy present. The next slide here depicts a lateral radiograph showing a combination of the findings from the two previous slides. Also, just have a look through this slide to familiarize yourself with the anatomy of the skull. Compared to humans, where the bones of the skull are quite thin with minimal soft tissue coverage, the skull and brain of the dog is very well protected by large muscles, for example, the temporal muscles, and therefore relatively infrequently injured compared to man. Cranial fractures are usually as a result of trauma, like a road traffic accident, a kick from a horse, or a significant fall. Animals that survive these often have minimally displaced fractures, and these would be seen as fine radiolucent lines, and we'll see one a little bit later on. CT and MRI are usually required, though, to detect intracranial trauma, for example, hemorrhage. Now, there's quite a wide variation in the skull types amongst dogs. Dolichocephalic are generally the long-nosed dogs or breeds, for example, the collie or the Irish Wolfhound. Mesaticephalic are your standard intermediate length dogs, for example, the German Shepherd or the Beagle, and the brachycephalics are the bulldogs, the pugs, and the Pekingese, for example. Here is a radiograph of a bulldog. One can see that the nasal chambers are much shortened compared to one of the other two skull types, and there's often prognathism of the mandibles seen present in these breeds. And this slide is an image of a radiograph of a pug, and it's very clear the difference in skull shape. It's very domed. The frontal sinuses have become very small. So in some cases, they disappear completely, and they've sort of rotated almost cranioventrally, and the nasal passages are markedly shortened. All right, the temporomandibular joint is aligned obliquely to the median plane of the head. So on a lateral radiograph, it's not seen properly because it's not seen end-on. One needs to tilt the nose of the dog so that the joint space is brought into a vertical position, making it parallel with the X-ray so that it will become visible. The TMJ closer to the cassette will be demonstrated. So if the patient is lying on his right side, the right one will be demonstrated. But usually we radiograph both sides for comparison for pathology. So here's some examples of how TMJ radiography is performed. So the median plane of the head or the nose must be tilted up or down by 20 degrees with the head in a true lateral position without any rotation. And again, this is achieved by using foam wedges. A similar projection can be achieved by having the patient in normal lateral recumbency and angling the primary beam by 20 degrees. However, one then needs to change the angle of the X-ray machine itself, and that becomes quite laborious to do. So it's easier just to tilt the dog's head. In the radiograph here, one can see the condyloid process of the mandible very nicely with the radiolucent joint space, and it fits well into the mandibular fossa of the zygomatic process of the temporal bone. The DV is standard as previously described. Symmetry, though, is very important to be able to compare both sides. So on these images here, this is the condyloid process here, fitting in nicely into the mandibular fossa of the zygomatic process of the temporal bone. So here's an example of some TMJ pathology. The right side is normal. So there's the condyloid process in the mandibular fossa. And on the left side, the condyloid process is rostrally displaced, and there's a radiolucent space between it and the mandibular fossa. Additionally, the mandibular symphysis is deviated away from the side of the luxation. The lateral view is not particularly helpful because of all the superimposition seen, but here one can see that the condyloid process is not surrounded by a nice radiolucent joint space, indicating that there might be pathology. Next slide shows similar pathology. Before reduction, the luxated joint is seen on the right-hand side. There's an increased radiolucency between the condyloid process and the mandibular fossa, as well as malalignment of the teeth seen as the mandibular symphysis being displaced towards the left or away from the side of the luxation. After reduction, the joint appears normal, and there's better alignment of these incisor teeth and of the mandibular symphysis. The frontal sinuses are quite tricky to radiograph. On lateral radiographs, they're superimposed over each other, so it's impossible to distinguish if the left or the right side is affected. The frontal sinuses might be the site of primary or secondary pathology, and so in these cases, we perform a skyline view, consisting either of the rostrocaudal or the caudorostral views. So this is an example of how to perform the rostrocaudal vertical beam view. The patient is placed in dorsal recumbency with the the nose pointing up, and the hard palate at a sagittal plane or vertical to the cassette. And then the primary beam is aimed at the hard palate and at the dorsum of the nose and centered on the forehead. So everything in line with the patient, parallel. The MAS needs to be reduced by 50%. This is because the frontal sinuses are air-filled, and otherwise it'll lead to overexposure. One can use positioning tapes and sandbags or even a Perspex box to obtain this view. And at the top, one can see the air-filled, bilaterally symmetrical frontal sinuses with a bony septum and a thin frontal bone covering each side. The other view that one can perform is a cauda-rostral horizontal beam. So the X-ray beam is aimed horizontally and will enter from caudally, exit rostrally, and then the cassette will be positioned vertically and held in place by positioning aids. It's a bit of a tricky one to do, and it's a bit laborious, but the benefit of this view is that any fluid that's in the frontal sinus will be seen as a horizontal fluid-air interface due to gravity. The next slide just demonstrates an example of frontal sinus pathology. The left-hand sinus is completely lytic and destroyed. There's maybe a little bit of remnant cortical bone, but it's lost that nice radiolucency that's present, and this is most likely due to a primary neoplasm of this area. Here's just an example of the lateral view of the frontal sinus. This was a cat that had a skull fracture, and one can see the subtle skull fracture over here in the region of the nasal bones going up until the frontal bones. It's a depression fracture. There's not much displacement, but the nasal bone is depressed a little bit relative to the other fragments, and the superimposed frontal sinuses are nice and clear. A week later, this area is filled up with soft tissue, and this was believed to be a result of either obstruction, drainage of the frontal sinus, or possibly hemorrhage into the frontal sinus. So the next step from this lateral view to determine which side is affected would be to do either a DV view or a rostrocaudal or a cauda-rostral skyline view. All right, the tympanic bulla can also be quite tricky to radiograph. In this case, we again do a rostrocaudal view, but we'll do it with the mouth open to highlight the bulla, and it will be demonstrated on this radiograph here. So general anesthesia is definitely necessary. The ET tube is removed just before the exposure is made. The patient is in dorsal recumbency, the mouth gets held open, and the tongue is pulled forward. So similar to the other view that we discussed, the hard palate is vertical to the cassette, and the beam will come down and be parallel to the hard palate. So this image at the top just shows what this view would look like. It's open mouth because here are the two mandibular rami, and one can see that the mouth is open. There are the zygomatic arches on either side. And now we're looking into the patient's mouth. Here is the cranial end plate of C2 with the dens. Here is C1 and the wings of C1. And then these two structures on either side are the tympanic bulla. In this case, the feline tympanic bulla divided into two compartments by a bony septum. And both sides should be gas-filled. This side appears to have a bit more soft tissue, which sometimes is a bit tricky to determine. Is it truly soft tissue inside the bulla, or is it just because this view is a little bit oblique and there's soft tissue from this surrounding facial structures superimposed over it? The lateral view can also be used to assess the tympanic bulla. For example, over here, unfortunately, there is superimposition of both over each other. There are additional oblique views that one can do to assess the tympanic bulla individually, but we're not going to be covering those in this lecture. So the most common pathology of the tympanic bulla is otitis media, and radiographically this is seen as an increased opacity within the bulla, replacing the normal gas opacity, and this is due to exudate or granulation tissue or sometimes the bulla wall is thickened due to chronic inflammation. On this open mouth rostrocaudal view, the right-hand side tympanic bulla has a markedly thickened wall compared to the opposite side, which is nice and thin still. And on this radiograph here, there's complete loss of the nice central radiolucency, or the gas-filled bulla, and there's marked thickening of the bulla wall, typical of otitis media. Right, the nasal passages can be assessed by a DV or a lateral view. They're good for screening, but there is a lot of superimposition which hampers evaluation. The single most useful view for nasal disease is the dorsoventral intraoral view. This is because there's not superimposition of the mandible. One can compare the left and right sides and therefore identify asymmetry or subtle lesions. So the patient is placed in sternal recumbency under GA. The head is supported with foam wedges or foam blocks, and then the cassette is placed with its corner into the patient's mouth. Usually this requires non-screen film or plastic envelopes with small detail screens and a lead plate. These aren't easily available, and unfortunately normal cassettes are too thick to insert into the mouth, except for much larger dogs. And what's nice about this view is one will get the entire nasal passage, including the cribiform plate, into the view. Alternatively, and it's not going to be discussed on these lectures, but one can look it up if interested, is that one can do an open mouth ventrodorsal view. So the patient lies in dorsal recumbency with its head tilted back and the mouth opened. And then the beam is aimed from ventrally to dorsally. And then one avoids the superimposition of mandibles by opening the mouth. So here's just a little bit of normal nasal passage anatomy on the DV occlusal view or the DV intraoral view. The nasal passages are split into rostral, middle, and caudal segments. It's split into left and right by the vomer and the bony nasal septum here. The middle nasal passages have turbinates, the ventral and dorsal concha, which are these fine mineralized radiopaque lines that we can see. The ethmoturbinates are located in the more caudal area of the nose. The nasopalatine fissures are these two radiolucent structures seen over here. The external nares are these radiolucent areas here in the soft tissue. And then all the teeth are on the maxillary bones seen in between the teeth. So the following is a table depicting the main nasal pathologies, so namely neoplasia, fungal rhinitis, chronic rhinitis, which could be due to bacterial, viral, or non-specific inflammatory causes, such as lymphoplasmacytic rhinitis, and then nasal foreign body. And some of the findings that will help differentiate them. So unfortunately, there will be at times an overlap, but by using this table, one can come to the most likely differential diagnosis. It's mainly applicable in dogs. In cats, differentiating rhinitis and neoplasia is much more difficult. So this table is most commonly used in dogs. Sorry, I just want to go back to it and to discuss it a little bit more. So for example, in neoplasia, it's much more likely to be unilateral compared to the rest. Foreign body is also likely to be unilateral. Bilateral disease is often mycosis or chronic rhinitis. Vomer erosion, trabecular destruction is much more common in neoplasia, although mycosis, especially aspergillus, leads to an empty nose almost. There can be marked turbinate destruction. Conchal turbinates, these are the ones that are more rostral. So mycosis, chronic rhinitis, and foreign body tend to occur more rostrally in the nasal passages, versus neoplasia, which is more likely to affect the more caudal ethmoturbinates, although mycosis can also affect them. Increased opacity is more common with neoplasia because it tends to be a soft tissue mass, whereas chronic rhinitis and foreign body tend to be more exudative. Maxillofacial bone lysis, soft tissue swelling, and frontal sinus opacification are all more common with neoplasia, chronic rhinitis and foreign bodies much less likely. So I've got a couple of examples of nasal passage pathology. Unfortunately, the images with the pathology are digitized hard copies versus the normal picture that I've got down here, which is a digital image. So they do appear a little bit differently. And unfortunately, a lot of nasal disease these days is assessed with CT. So it's quite difficult to find nice examples. But nevertheless, we're going to be looking just at a couple of things. So the typical radiological signs of neoplasia is lysis of the bone around the margins of the nasal passages or nasal cavity. Usually all parts of the ipsilateral nasal cavity is affected. It can be generalized unilateral or bilateral increase in soft tissue opacity. The ipsilateral frontal sinus may often be involved, containing fluid or soft tissue opacity, and there tends to be a generalized loss of turbinate detail, and the vomer or the nasal septum is often destroyed. So in this example that I've got here, there's bilateral patchy increased opacity. So there's regions here where there's increased soft tissue opacity. There's a generalized loss of turbinate detail. Compared to the normal image, these little striated mineralized opacities are all absent. There's complete loss here of the central part of the nasal septum and the vomer. And then there are these radiolucent foci, which shouldn't be here. And that is consistent with lysis of the hard palate. So in this case, it was an advanced case of nasal carcinoma. The nasal tumors in the cat are quite rare, and they're not that common in the dog. The long-nosed breeds, so the dolichocephalic breeds, or older dogs are more commonly affected. Clinical signs are typically unilateral nasal or ocular discharge, epistaxis, stridor, loss of smell, and loose teeth or loss of teeth. Later on, there might be facial deformity along the dorsal aspects of the maxillary bone and over the paranasal and frontal sinuses. Most nasal neoplasms arise from the mucosa of the nasal cavity and the frontal sinus, and they're malignant, for example, adenocarcinoma. Spread is usually by local invasion and occasionally by the lymphatics, and benign neoplasia is very uncommon in the dog and the cat. Right, on the next slide, we'll be looking at a bit of chronic rhinitis. Typically, the radiological signs could be a nasal radiograph that's completely within normal limits, loosened foci, focal or multifocal lesions, especially more rostral in the nasal passages, or more localized soft tissue opacities. So in this case, the asterisk indicates a large radiolucent lesion here, where there's complete loss of the nasal turbinates, if you compare it to the opposite side, which is still intact. And this was an example of fungal rhinitis. So aspergillus tends to be very lytic, leaving an almost empty nasal appearance. Other causes of rhinitis might be allergic, hyperplastic, infectious, foreign body associated, or secondary to dental disease. The classification of chronic rhinitis occurs when inflammation is severe enough to cause structural changes in the mucosa that comprise the immune function. Right, and then with the foreign body, it depends on what the opacity of the foreign body is. For example, in the image on the left, this was a piece of electrical insulation, apparently, that's quite radio-opaque and makes it easy to visualize. In the right-hand image, there's also mineralized material in the right nasal passage. This could be dental material, for example, and it's a little bit difficult to see, but there is this whole region here of very subtle increased soft tissue opacity compared to the opposite side, where there is still visibility of the normal turbinates. Most commonly, though, grass seeds and plant material are the common foreign bodies that are found, and they're not visible on radiograph. So in these cases, one might see just a focal soft tissue opacity with turbinate loss. And these days, if in doubt, we tend to do nasal passage CT. For example, on the left-hand side, the left-hand nostril is completely devoid of nasal turbinates. The right-hand side, these fine little squiggles, that's all normal nasal turbinates. And this is a very typical appearance of fungal rhinitis. So again, aspergillus, where it leaves the nose to appear almost completely empty. On the right-hand image, the right-hand side of the nasal passage is completely obliterated by soft tissue material. There's loss of the nasal turbinates. The nasal septum is destroyed with this soft tissue invading the opposite nasal passage. And there's also lysis of the hard palate and of the maxillary bone, and even a bit of soft tissue swelling on the outside. So from this, you can see that CT enables a more detailed examination of bones compared to radiography, and will help identify what the lesion might be from. In rhinitis, CT will normally show variable degrees of nasal exudates, accumulation and turbinate loss. It tends to be more multifocal and is more marked rostrally in the nasal cavity. CT is also very useful for detecting fluid in the frontal sinuses. And then just lastly, MRI can also be used. It's better for soft tissue. For example, here there was a nasal neoplasm on the one side, which has shown some contrast uptake and invaded into the brain via the cribriform plate. So whereas MRI is not typically used for nasal disease, it can add a lot of information, especially if there is intracranial invasion. Right, and that's the end of the nasal and skull section on the DIM 400 radiology lectures.